Hello, everyone. I'm Dr. Harold Koenig, and welcome to this month's seminar on religion, spirituality, and health. We are so excited to be able to have Dr. Keith Meador give the presentation today. Keith has been a close friend and colleague for over 35 years, and we co-directed, we co-established and co-directed the center for many years until he moved to Vanderbilt. But in any case, Dr. Meador is professor of psychiatry and health policy at Vanderbilt University Medical Center, where he serves as the director of the Center for Biomedical Ethics and Society. He is also professor of ethics and society at Vanderbilt Divinity School. He serves as director of the Integrative Mental Health, a national initiative to support integration of spiritual care and chaplaincy into the mental health care within the Veterans Administration. He is a physician, board certified psychiatrist, and with training in theology and public health. Dr. Meador is a Phi Beta Kappa graduate of Vanderbilt University and received his medical degree from the University of Louisville. Especially important is that he completed his residency in psychiatry and fellowship in the Aging and Human Development Center here at Duke University, and his theological education leading to his Master's of Theology was at Duke Divinity School. He's also received an MPH in epidemiology from the University of North Carolina at Chapel Hill. So Keith is going to talk to us about diseases and deaths of despair, interpretation and responses as practices of care. So Keith, take it away.
Thank you so much, Harold. Thanks for that kind introduction. And yes, I remember those early days of psychiatry for both of us. They we have gotten a bit older, haven't we, my friend?
We have.
Yeah, it's all good. It's all good. Well, I am delighted to be with this group today. It's really a special treat for me to have this opportunity to join you. And I hope that this topic will be one that you will see over time as we look at some of the issues today together. We're going to bring a number of lenses together that I hope will be interesting for you. A lens of political science, sociology, psychology, psychiatry, ethics, and theology. And we're going to try to weave a tapestry that includes considerations and interpretations along through all of those threads. Where are we going together? First, we're going to look at illusions and seduction of the therapeutic culture and the notion of the happiness industry. Some of you have heard me talk about some of those before, but I want to incorporate in some current concerns that and some notions that William Davies out of the UK has contributed to the way I'm thinking about this. We want to then look at diseases and deaths of despair in context. What's the cultural and societal context in which we've seen substantive, I think, losses in lives, but a lot of suffering, even with just the diseases that I think come from some of the despair in the context of our current culture. We want to look at communities of care, and as an alternative to the communities that have fostered those contexts, think of ethics of care and practices of care as a frame of how to think about caring for within these communities. And then ultimately look for possibilities of in communities of care and practices for the care of humans. And you'll see how important that is to me when that notion of the care of humans as we go through our time today. First, I want to name a concern that I think has something I worked with through the years, but it continues to be an issue to me, of a therapeutic or a prosperity culture. Those of you more from the theological domain or the pastoral frame of reference would think of prosperity gospel as having some relevant comparison in thinking about this. And I do think these concerns that I want to name are relevant for both the healthcare arena and for those of us who are members of faith communities and parts of, and as part of our practices of our lives. And so I kind of, there's two sides to this, to the coin here that are relevant and will come out as we continue our discussion today. But first, this notion of technological utopianism. Jerry McKinney, a theologian and philosopher at Notre Dame, has coined this in his book, To Relieve the Human Condition. And it really, I think, is an apt phrase for thinking about the assumption that if we just have more technology, everything will be fixed. We will heal each other, people will be healed, people will be living without suffering, etc., if we just have adequate technological innovations. I think that's an illusion, my friends. That we can eliminate suffering is also one of those sort of aspirations. And again, I want to make the point, and we'll discuss this further, that I'm not saying that suffering is a good thing. I'm not trying to foster suffering by any means, but I think it's a prevalent illusion at times that to assume that we can eliminate suffering. And I think that's problematic both from a theological as well as a healthcare perspective. We have heightened consumerist expectations, I think, as part of this therapeutic and sort of prosperity culture that we have lived within. And I think that distorted heightening of consumers' expectations has been a great disservice, both in healthcare and in faith communities. And ultimately, I think this context of therapeutic culture and prosperity gospel as part of that therapeutic culture has included a presumption of fixing the disordered. I think we've been much too captive to the idea that if we just find ways to in some ways to fix the disordered, we will have fulfilled these prior goals I've been talking about. And I think the illusion that we're going to fix anyone is a disservice to the humanity of that person, as well as has a bit of a hubris on our own part included within it. A visual image just to sort of bring this home for us. I love this notion of, please forgive me, those of you who are engineers. It's not meant to prejudice toward you, but this flow chart that I've seen through the years of the illusion of that all we need is either WD-40 or duct tape, and that if we just have that, any problem that presents itself can just be, quote, fixed. If we just know if it needs to move and it doesn't move, well, it needs WD-40. If it moves and it doesn't need to move, it needs duct tape. And I fear that we live our lives more like that than I wish we did. I fear that we're very captive to that idea in so much of what we, especially in what we do within healthcare. But I think it's also a presumption that we live within faith communities as well. A classic reference on this notion is Philip Reef, a classic work from The Triumph of the Therapeutic from 1966, where he talks about the manipulable sense of well-being. And I want to highlight that word of manipulable. And what that implies is that someone is the agent or controller within that manipulation. And some of what we want to talk about today is I'd like to think about with you the notion where therapeutic is actually perhaps a bit of sheep's clothing put on the wolf, as far as that if we're not careful, I think we have seen through the years, how the therapeutic has become a commodified happiness and prosperity that's really different than what I think we want to use so often when we were talking about the very real therapeutics and caring for those who are suffering. And so that distortion of therapeutic that I think has been propagated by what you're going to hear me talk about today, of some of the industrial capitalism of healthcare and market-driven forces that have really become operative in so much of our way, how we in how we think about both healthcare and how we think about our life within faith communities. This is a recent book from 2019 by a scientist of, a historian of science at Harvard, Ann Harrington. And the title speaks volumes in itself, of Psychiatry's Troubled Search for the Biology of Mental Illness. We've learned so much in the biological domain over the last 50 years with regards to psychiatry, but I think one of the great faults that we have to bear as practitioners within that field is the notion of the reductionistic presumptions that we have had about, oh, it's a biological disorder. We can fix this if we just find the right medication to adjust the right neurotransmitter, etc. I'm going to propose to you, my friends, that besides being an illusion, that's a great disservice to those we care for. Just a reminder through this graphic of that really we need to be thinking in terms of when we think about these relationships we're talking about today, that we're thinking about a large ecosystem. That's an ecological commitment, an ecological and systems-oriented understanding of how we're trying to think about health and human flourishing. This is a book that if you have not had awareness of, I introduced to you, I showed you this picture just so you'll have awareness of William Davies and his work. I'll be sharing some thoughts that I think he has rightly brought to the forefront. This is a book from 2015 that he's basically sort of political science and sociologist in the UK that I think we're going to find useful to us in thinking through some of these issues. Davies points out that what we may not need is more science of happiness or behavior. That really that may be a distorting effort and enterprise, and that if we look more carefully, what we may need is to start to ask really serious questions about highly unequal societies with strongly materialistic competitive values, and how that's a disservice and actually may really be a contributor more than to problems around whether it's emotional mental health and actually just not thriving when we think about the domain of human flourishing. Before we get into this too heavily though, I want to share with you the great wisdom of Dilbert. We've moved past the old notion of customer loyalty, the CEO is saying. Now we use science to manipulate dopamine and create addictions that make a mockery of free will. Dilbert naively and astutely asked, that sounds like the epitome of evil. CEO, we call it extreme marketing. I fear that we are all captive to extreme marketing in a variety of ways. And that while I think Dilbert has it right on target when he talks about the epitome of evil, that I fear we are very easily captive to the idea of using science to manipulate dopamine and create it, and with the illusion that we can just avoid whatever despair or whatever potential distress might be there if we can just manipulate and gain control of that, and no longer do we worry about humans having any free will, but that humans are just to be manipulated automatons. In this risk, I think we have to struggle with the notion of the degree to which these efforts that we so often are propagated within in our work with science, within healthcare, etc., that we often propagate blaming those who are suffering for their own misery. And that an example might be, I'm using this quote where he's talking about Jeremy Bentham and utilitarian measurement techniques. And I commend this book to you if you're interested in in some of the topics that I'm bringing up with you today. But the idea that literally we can become so captive to measuring and the surveillance of human beings that we start to blame them for not being better, for not in some way getting better and fulfilling our aspirations for them, to fulfill our illusions of that therapeutic culture and that prosperity culture. And they end up suffering from our utilization of these tools because they have not succeeded, even as been a good patient in some way. And I use this to start to introduce to you the notion of just the consequences of this science of happiness, that it ultimately, where it can ultimately lead with regard to the infrastructures of measurement, surveillance, and government. But I want to, and I would propose to you that along with government, this can be issues of healthcare and religious life, that we can, if we're not careful, what Davies is pointing out as the science of happiness starts to become an entangling of hope and joy within all of these infrastructures of what I'm going to be talking about as a neoliberal society and communities. But important is that I am not wanting to denigrate the ethical value of happiness, as Davies says here, less still to trivialize the pain of those who suffer from chronic unhappiness that are depression and may understandably seek help in techniques of behavioral treatment. I am in no way wanting to detract from getting good treatment, but I want us to think about what the implications are of this broader agenda that of measurement, surveillance, and that is really perpetuating the science of happiness. So let's talk some about diseases and deaths of despair. And I'm going to focus on suicide, admittedly, because that's a particular consequence, but it's also, it's a consequence really of more of the broader picture so often of the opioid epidemic and just substance abuse in general that has been so much a part of this story, that Case and Deaton, Ann Case and Angus Deaton, are who really I give credit to for this name of deaths of despair. And we're going to look a little more closely at a comment they make. But I want to focus on, just as a place to highlight, the suicide rates that have been rising in the US throughout the 21st century. What's happened over the last 2 decades? Why are we seeing these increased suicide rates at the level we're seeing them? What's operative in that? How might we think about those losses now? Case and Deaton have nicely documented sort of a vision as economists of some of the realities of the last few decades, and just the changes in the cohorts that have what would be middle age Americans right now, with a focus in their work on particularly the undereducated, less educated white population. But if we look at the total suicide rate across the population, we still see this significant increase. And I think it's relevant to think about the notions of despair that we're going to, and the existential realities as we look at the possibilities together and the populations we want to think about together. Now, what else has been happening over the last couple of decades? These are not, and I want to make sure that I'm really that I emphasize, these are associated realities. I'm not proposing these as causative and do not have data to support that, but I think they're associated in ways that are instructive to us to think about and to learn from. And we, Harold alluded, some of you may have heard earlier talking about Jason Newsma, a colleague of mine in our integrative mental health program, that has put some of this together, of nicely showing the multiple contributor or multiple associations over these last 2 decades with this increase in suicide risk. And one that might be particularly interesting to our group today is this decrease in religious affiliation. Now, is that causative? Is that causing the increase in suicide? I think there are many contributors to that reality, but I think they're all interesting and relevant for our consideration. Case and Deaton, the folks who have, it's actually a husband-wife team of economists at Princeton that have developed this, that coined the phrase deaths of despair, that I think is quite pointed and useful to us, have said, having a meaningful job, good family relationships with a spouse and children, and belonging to a church that helps address spiritual needs all help maintain a life that is worth living. Their increasing absence among white Americans without a university degree is a disaster. That's a pretty powerful statement coming from Princeton economists, that they would be clustering those issues and the void in the lives of non-university degree white Americans as a configuration contributing to the suicide, opioid epidemic, etc. I think that's notable. And I think it's one of those that we want to ponder together as we think about some of the broader cultural issues that I want to continue to bring out for you. So let's talk about this notion of neoliberal communities and just what that means. And the phrase there's a lot of diversity, I'll leave it that way, of what that means to talk about neoliberalism. But fundamentally, I think I'm going to work on this a little bit more with you, but it's talking about market-driven, competitive cultural realities, and the assumptions of that of a meritocracy in so many ways that we deserve what we get, and so your choices you make and those things that you engage in as an agent of manipulation, etc. That those are the determinants of the outcomes for persons. And one of the realities of that ends up being notions around suicide. That so often, this is a New York Times article written by Vice Chair of Community Psychiatry at University of UC Davis, and I pick out this particular quote for you of that we so often start to blame those who are suffering with significant depression and then ultimately suicide, as we blame it on the person themselves or their families, much to the destruction of a sense of possibility or a sense of hope or for these persons who are actually frequently trapped in poverty, homelessness, exposure to trauma, crime, and drugs. I think where she's challenging us around that better alcohol and drug treatment, family counseling, low-income housing resources, job training, and individual therapy, that these might make a difference. I think we have to struggle with that. We have to really sort through where are we going to attribute accountability, and where are we going to what are we going to consider as important potential interventions societally. Michael Sandel who is an ethicist at Harvard and teaches a huge course every year around the good, around what we think of within an ethical perspective as a common good, has said that viewing health and wealth as matters of praise and blame is a meritocratic way of looking at life. I want us to really think about what this means. Such hubris is not only found among prosperity gospel conservatives and libertarian critics of the welfare state, it's also a prominent feature of liberal and progressive politics. This is not, I want to make sure I'm making the point today, this is not at one end of the political spectrum or the other. And I think that's what I really want to get out of this Sandel quote, is to emphasize to you that this notion of that we are, all of our outcomes are dependent on our choices, and that it's choices we make and for the way we live, that assumption is not one of either the right or the left from a socio-political perspective. This is a deep-seated, deep-rooted assumption that has been long-standing within our culture and with major ramifications for us. I want to spend a little time on this one because I want us to really digest and start to really process the notion of what it means when Davies talks about the depressive competitive disorder of neoliberalism, and how this comes out of, if you think the Chicago School of Economics or St. Louis School of Psychiatry, if you know those two, those are very much, some would say that they are very dehumanizing schools of thought, whether it's in psychiatry or whether it's in economics. The logic that says we have a particular political or moral responsibility towards the weak, which may require us to impose restrictions on the strong, is broken. The implications of thinking about that, my friends, of if we have no moral or political responsibility towards the weak, what does that mean? And I'll remind you that a particularly historically significant group of people who would have taken that position would have been the Third Reich during the early 20th century. Dietrich Bonhoeffer, who a name many of you will know, who was really a significant ethicist and theologian of that era, died a martyr's death, responding to this sort of presumption of the Third Reich that we have no political or moral responsibility towards the weak. And this I think part of what has fueled these diseases and deaths of despair process is embedded within that neoliberal assumption of that just those who are most effectively competitive and who are prove themselves to be the strongest are those to be rewarded with no moral or political responsibility to those who are weaker. Think about what that means for us. Think about the implications of that, but societally, but ultimately also for the individuals who are suffering. Bruce Rogers Vaughan is a colleague of mine here at Vanderbilt Divinity School, and he's written a book in 2016 that I think it's kind of dense at times, I confess to you, but I think he's on target here in a very profound way. When he says, I'm going to read this slide because I think it's important what he's saying. These unfortunate souls, these souls that are captive to this depressive competitive disorder of neoliberalism that Davies is pointing out, these unfortunate souls are abandoned, left to interpret their sufferings as signs of personal failure. They are not guilty, they are ashamed. They do not have adequate narrative resources at hand to understand, to make sense of their sufferings. I want you to really digest this of what it means when we're telling people, when the messaging we're giving is that people are a failure because of their suffering and fostering a sense of shame for them because of their suffering, literally. They are left simply with market-generated narratives of personal recovery. Such narratives are window dressing, the notion of, well, if you just do this or do that, you can be fixed. A veneer of order imposed over what once would have been a durable sense of self. So what we're having here, friends, is that this sort of neoliberal communities are fostering this sense of personal failure and shame that ultimately leave the void of persons with a real loss of their sense of self, you could say self-worth on some, but I think it's more powerful and more appropriate. So they really have a loss of a sense of self. The consequences of that, I think, are profound. I think the failure and the shame lead to really a significant existential despair. Those of you who've known me a while or may have heard me talk before know that I think communities are important. But communities can be and I think they're powerful, but they can have negative implications or positive implications. And I think what I'm wanting us to digest here, as the previous slides indicate, communities of neoliberal communities, I think, can have powerful negative consequences in the in the spirit of this failure and shame that leads to an existential despair. Corbin has said in a New York Times editorial just last year, weakness has a special sting if you understand it as a moral failing. There's an assumption that mastery is our natural proper condition, and if you aren't capable of it, you're defective. Think about the messaging we're giving within our neoliberal kind of competitive disordered context, where when we're telling people that your weakness is a moral failing, and the assumption that if you aren't capable of the natural proper condition of mastery, you're defective. I fear that so often we are, not with malice, but because we are culturally captive, that we are messaging to those who are already suffering that your lack of mastery, your lack of being the natural proper in the natural proper condition of mastery is a sign of your defectiveness and that you are a moral failure. Sandel, again, commenting on young people he works with, talks about their striving and their years of trying to live up to the expectations of parents, et cetera. And my friends, if when I start to read this one and I think about the multiple times I perpetrated some version of this on my own children, you're not alone if you're having that thought as you're reading this with me. We've all done our parts, and I want to take this moment just to reflect on, we're all captive to this. This is not something I'm saying, oh, this is X or Y, this is you or you. No, this is a cultural milieu and a context in which we all live within. And I wanted to raise it up for us to ponder together, to think about, what does it mean that we live within this context, and what are the implications and consequences? Success or failure at meeting the demand to achieve comes to define one's merit and self-worth. I think there are real consequences. Broadly conceived, we could talk forever about some of this, but I think the implications for those whom we would care for and love within our families are very real. So, okay, communities are powerful for what they can do to harm, but I want to propose then some possibilities for how we think of communities as responding with care, and we've seen some of the sort of, I would say, the tragedies of the context in which we live, but I think all of us who are together on this call today have some hope and aspiration for that. We want to challenge that. We want to be agents in some level of mitigation of those issues. First, just to clarify what we're talking about when we think about health, I just want to emphasize for those who might not have known the way I think about this before, that when we're talking about the health, we're talking about human flourishing we're not talking about absence of disease, again, or being fixed, but we're talking about a flourishing in the midst that acknowledges, and you'll see why this is so important in a few minutes, that acknowledges the disappointments in life, and that acknowledges that one can have a flourishing and a fulfillment in the fullness of life while living with the inevitabilities of our suffering and our awarenesses of our humanity. Those of you who know me well know that I can't give a talk without at least one Wendell Berry slide. So I share with you this classic phrase from his Health is Membership, where he says, health is not just a sense of completeness in ourselves, but also it's a sense of belonging to others and to our place, is an unconscious awareness of community, of having in common. This is awfully important in the end for where we want to go, friends, of a sense of belonging to others, a sense of belonging to others and to our place. framing these communities that are going to have a positive influence. As I noted, communities are powerful one way or another. I do think communities, going back to Alistair McIntyre, et cetera, are profoundly powerful in our lives. But the issue is, what kind of communities will they be? And this is where I bring in just a little bit of a tincture of ethics just to this conversation with you. And we're going to be talking about ethics of care as I think formative language to be used in thinking about forming constructive communities, in contradistinction to strict utilitarian outcomes, which are based on the expectations of a neoliberal assumptions of a standardized model of care. This is just a quote from Zeke Emanuel, just to highlight that political communities that can deliberate on matters of good are a necessity for finding the good life together. And I lament that we struggle so much in our current context to have those conversations in a deliberative and civil fashion. This is just an image to help give you a sense of just the importance of what I think of the practices of care being formed within communities and systems. And that if we're really going to have systems of care, and all of us in healthcare aspire in some ways, I think, or I shouldn't say all of us, many of us in healthcare aspire to have better systems of care. But if we're going to really, if we're going to have those, we've got to think deeply about what's contributing to those communities, and how do we examine our captivity to what I would call those neoliberal assumptions that we're so embedded in, and how do we think about a more full ethic of care to inform that. So this formation and ethics of care, I want just to give you just a taste of this. We don't have time to do it in depth, but just to introduce you to the notion of ethics of care that came out of work of Carol Gilligan and a number of others, where they talk about the understanding of responsibility of relationships, and that this conception of morality is primarily framed around the activity of care. And while there are various ways we can discuss this and pros and cons, and it's not exclusive to other ethical frameworks, I think it's just a contributor to the rich conversation that needs multiple sort of lenses brought together in thinking about ethics. But just the understanding of responsibility of relationships is a centrality that I just want you to retain and think about with me. Joan Tronto has I think, captured a notion of what care is about as both a practice and a disposition in a powerful way here. And I love when she talks about the repair of our world. A colleague, a friend had mentioned to me earlier today, Bert Kaplan, who many of us will remember from many years of supporting this gathering, Harold, and Bert's commitment. And he's a profoundly wise Jewish colleague to talk of tikkun olam, to repair our world. It's a phrase I treasure. And I think Tronto's right on target to talk about care as being fundamentally about the commitment to repair our world so that we may live in it as well as possible. Virginia Held has tuned that a little further in talking about the issues of practices of care. And I want to focus with you here on that. It's easy to think sometimes about, well, I'm caring, I'm doing things that are caring, I'm engaging in activities, I'm doing work as care. But Held kind of challenges us but if we really want to think about practices of care, and I want to challenge you that that's an important paradigm for considering, we need to think about the values that are informing that commitment to do that effectively, and with a commitment to care that's value driven and value laden, and that's a practice rather than just a work or a labor of care. and is important for when we're thinking about the refinements of how we're using this language. And then ultimately, I want to take us to an important part of care that Rowan Williams has challenged us, I think, very wisely about. That it's very easy to so often think about care as just something we're doing to someone, or that we're going to care for someone in some way that implies, I think, a lack of honoring the notion of what Rowan Williams calls solidarity. Now, Williams, in case you don't know that name, Williams was the Archbishop of Canterbury for about a decade, and I think is one of the true wise men of the UK. And he has written this in an essay where he was commenting on the work of Marilyn Robinson, who, if you have awareness about her work as really as a writer and novelist about Gilead, she wrote Gilead, she wrote Lila. I think William Robinson is a profound author, and Rowan Williams here is talking about the pushing us around the issue of solidarity with those who we would care for, to what it means for us to be bound to one another, shaped by one another, to the extent that none of us can be brought back into a full healing relation with God without being brought back to one another. The necessity of relationship, community, formed in particular ways, I would propose to you within this frame of an ethic of care and commitment, but with a high, with the standard raised even higher by Rowan Williams for us about solidarity with those we would care for. There's a framing there, my friends, that will make a difference when we're trying to challenge and when we care for folks within this who have been in some ways, I think, victimized by neoliberal communities. So what are a couple of practices of care that we can think about in response to this existential despair and the shame and the sense of loss and lament that is so common within the broader cultural frameworks that I've been describing? Well, one of the ways I like to think about this, as we use this image within our work in the VA, is the notion of getting upstream. This is with regard to suicide prevention, but I want to broadly say, some have used the phrase "causes of the causes." That really, what I want to challenge us when we think about the deaths of diseases and deaths of despair, and how we might, as communities of practice and faith, have potential to use a lens that might in some way get at the causes of the causes within in things like whether it's suicide, whether it's the various contributors to these diseases and deaths of despair. How do we what are some ways we can get upstream? Well, I want to describe two examples to you that we can talk about later if we have a little bit of time. That I hope we do have. I love the work of friendship benches. I don't know how many of you have heard of this, but it actually has been. They've done randomized controlled trials in both in Zimbabwe and then in New York of the benefits with friendship benches. But I really don't want to get lost in the randomized controlled trials, to be honest with you, because I'm more intrigued in some ways by the fullness of what it means to they literally, due to lack of mental health providers, started engaging what they called the grannies, the elder women of the community, to sit on benches, and those who had cares, those who had struggles, would come and sit with the elder women of the community on friendship benches. They would sit, and these were not women with mental health degrees by any means. They didn't, thanks be to God, they didn't have mental health degrees. They just knew how to love and to listen. and to care for folks. And so this notion of friendship benches got started in Zimbabwe due to the lack of mental health providers, and then has been taken and been shown to be effective in the middle of New York City as well. So I want to challenge us to think together about what this embodies on friendship benches. I mentioned to you here a classic book in pastoral theology, Lament for a Son, written by Nicholas Wolterstorff. Some of you may be familiar with it. Lament for a Son. Wolterstorff was a philosophical theologian at Yale for many years. He's retired now, but he wrote a book after his young adult son died in a climbing accident in Europe. And Wolterstorff at that point was already a significant theologian, etc. But he wrote this little book in which he pointed out the tendency for many people to want to speak platitudes of some sort to him, etc. when he lost his son, when he said, really what I yearned for them to do was to sit by me on the mourning bench, to sit with me on the mourning bench. They didn't have to say anything. The time spent sitting on, I think friendship benches are in some ways just one outgrowth of the notion of the mourning bench that Wolterstorff so nicely articulates in Lament for a Son. So ponder it with me. Think about what it would mean for us to embrace and develop in all sorts of contexts and ways, thinking about friendship benches. Then I want to challenge you with a practice that those of you who are involved in mental health care may know about, acceptance and commitment therapy, and it's something that we use in our work within integrative mental health. But I also want to highlight that it resonates with much of what I'm trying to name for us of the challenge of how do we address the struggles that are interjected into our culture and in our lives by these neoliberal communities that I'm talking about, and the propensities for the competitive depressive disorder that Davies mentions, and the lack of the perpetration of shame and existential despair that gets really propagated by so much of this context that I'm describing. I think acceptance commitment therapy has a distinctive capacity for potentially really offering a window that we think offers a window for allowing for disappointment, allowing for the realities of our thoughts, our emotions, our feelings, allowing for them. And then I think particularly the practice of diffusion within acceptance commitment therapy as part of the sort of acceptance mindfulness component of ACT, where we really nurture the capacity for folks to start to separate the thoughts and feelings they're having from that sense of self, or that what Bruce Vaughan talks about as that soulfulness that is so important, that's really being attacked and destroyed so often by the neoliberal agenda within our broader culture. So I just want to name the potential within ACT, and for particularly some of the reasons that here are premises of ACT that I hope you'll get a sense of why it fits it so well. That psychological pain is normal, it is important, everyone is going to have it. This is part of our life together as humans. You cannot deliberately get rid of the psychological pain. You can take steps to avoid increasing it, and that ultimately we can live lives of value, that we can live lives of value shared within a community, grounded in what I would propose to you, some of this framework of ethics of care, et cetera, that we can discuss more. So ultimately, we get to finding interpretability, meaning, and values in practices of care. And I think folks that are suffering with this notion, this sense of failure and shame and existential despair that I think the cultural context can lead to in so many ways, So many ways, I do think that some of the therapeutic, what I call a therapeutic and prosperity culture, and the neoliberal sort of communities, they really are just, I think, sort of various manifestations of a long history that we're living out together, but that is not easily challenged. But yet, I think how do communities of care start to respond to that for humans who are frail, vulnerable, and suffering? They're just as part of the human condition. Where do we find a shared hope in the midst? Douglas Rushkoff, who's clearly he's not a theologian or committed in some of the ways that we're articulating today, but I think he's right on target when he talks about that we humans are a part of a same collective nervous system. It's not a religious conviction, but an increasingly accepted biological fact. We can't leave anyone behind, or none of us really makes it wherever we think we're going. You know, I think he's got something there, and we need to digest it and ponder it together. Zuboff, who is an emeritus professor from Harvard's Business School, I think is challenging us of a very real issue that we're facing. This book is way too thick to read, to spend too much time with, but I confess it was significant for me. The Age of Surveillance Capitalism: The Fight for a Human Future. I think it's well worth your time to read reviews of it, at least if you don't read the book. But where she talks about machine processes replacing human relationships so certainty can replace trust. It's easy to get sucked into the yearning for certainty and fixing that are part of the therapeutic prosperity culture we're talking about, that is also part of neoliberal capitalism. All of that it's a full sort of seductive force that is powerful in our lives, and it's propagated currently, I think, within much of the surveillance society that we're being caught within, to replace. But if we become totally captive there, with supposedly the light in the we will have replaced human relationships, and we will have with machine processes, and I fear we will have replaced the necessity of trust, and the loss of necessity of trust, I think, will destroy us and will distort who we are as human beings. So as we wind up, at its most, I love this quote from Davies, where at its most fundamental level, the choice between Jeremy Bentham, and utilitarianism, a behaviorally determined, pain and pleasure oriented understanding of humans, and Wittgenstein, who is more of an intentional meaning making and narratively derived understanding of humans, it is a question of what it means to be human. And I think, friends, that this is really fundamental to how we think about spirituality and health, and how we make these connections together ultimately depends on how what we think about it, of what it means to be human, and how we think about the care of humans. A phrase that I've used for many years, that anyone who's worked with me in the clinical context and other contexts knows, that when I talk about therapy, psychotherapy, caring for others, I talk about seeking to transform unbearable pain into livable disappointment. And you may understandably feel like, well, Keith, I don't really want your therapy if livable disappointment's the best you can do. I think livable disappointment is our human condition, friends. And I think that's it's not bad if we can seek that together. And then finally, in conclusion, Jamie Smith, who's a professor of philosophy at Calvin University in Michigan, has written recently, and I love this, I wanted to share it with you. Those of us who come out of the Christian tradition, I realize everyone here may not, those of us who come out of the Christian tradition, I'm delighted that Harold gave me the opportunity to speak with you during Holy Week and the fullness of that. And I love when Jamie Smith talks about that Marilyn Robinson's art has found a way to say love. And I actually teach a class here at Vanderbilt Medical School where one of the lectures I give is on love. I tell the students always, this is the only course you're going to hear at Vanderbilt on love, and we qualify it healthily, hopefully. But I think it's important. Jamie Smith is noting that it really was a challenge to him in his way of thinking about how to engage the world, and that her art found a way to say love. Her words found a way of incarnating the grace at the heart of the gospel. The novel is a better match for the mysteries of mercy embodied in the crucified one risen. And in our imagining, we may learn how to be human again, learn how to be empathetic and live with one another, just to the extent that we see one another again in all our fractured complexity and mixed motives and dogged hopes. I think these are wise words from a philosopher who has grown to realize that he needs to read novels more, and he needs to spend time. It's out of a series called How My Mind Was Changed. It's actually a very nice piece by him, and it's very touching. But I think he's on target there when he talks about what it means to be human again and learn how to be empathetic and live with one another. And finally, I go back to friendship benches, friends. May we be people who nurture the development of friendship benches, and that and spread tikkun olam in the midst of the friendship benches. Thank you for your time today. Appreciate the time.
Thank you, Keith Meador. What a brilliant and inspirational talk. So now we're going to open it up for questions. Go ahead and unmute yourself and ask your question to Keith. And hopefully we won't get an echo when you unmute yourself, but go ahead, let's try it.
Yeah, Dr. Meador, this is Aaron Fuller.
Hi, Aaron.
Always good to listen. Always good to listen to what you have to say on this topic.
It's good to see you, my friend.
Yeah. I think, thinking about the pandemic and looking at, there's a major push, and I know in the DoD this is true, but I'm seeing it across everything. More of an emphasis on telework, machine learning, algorithms for in healthcare, biosensors. So you're seeing this whole kind of move towards kind of a technological, which I think we can say is people maybe feel connected to data, but is it really getting at I think the topic today kind of gets at there are some challenges with that. Maybe you can comment in terms of just kind of from a standpoint of public health. How do we engage that conversation with people that are just like kind of bought in the idea of like, well, we can save money by teleworking and be as efficient, machine learning and delivering healthcare and a bunch of other measures that way is definitely the way to go.
Yeah, no, Aaron, that's a great question. Very thoughtful as always, as you are. Where I would kind of approach that is, I'm intrigued with this thing about the algorithmic machine learning that's being used like to predict suicide. And some of the, there's been real, a good bit coming out recently about that. And while the epidemiology side of me and that dimension of who I have been through the years finds that intriguing and finds it and can sometimes feel like, oh, well, that could be useful data to have in management of a healthcare system. I do worry about it, Aaron. I worry about what it means about how we just even the whole notion of the surveillance of human beings. And think about what it means if someone's told we've assessed our algorithms of XYZ healthcare system have determined that you are particularly susceptible and vulnerable to suicide. And when you hadn't really been saying that you were actively suicidal, but think about the ethical implications and then what it means for that person as a human. I think there are real significant questions that come up with these. And this is an example of where I think we're all living in a world that is in so many ways governed by neoliberal capitalism. by these influences. We're all captive to it in so many ways. I'm just trying to chip at asking the questions of what is it doing to us? What is it doing to us, and what is it doing to those people we care for? And I think it's substantive what it might be can do. And as you know, Aaron, I mean, one of my commitments is always that there's no substitute then, but for that time you spend on the morning bench or the friendship bench with the person that you're caring for in the DoD, serving them. So
No, and just a follow-on comment is, I wonder if it's just, if this whole like movement you're talking about or reality is basically pushing people into like various forms of ideological fundamentalism.
yeah, I think you're right on target. Actually, Aaron, I think, and think about how, I didn't get into this today, but I think when we talk about shame, there's what we call trait shame and state shame. That where it's a trait for someone and whether it's just in a particular context. I worry about the propagation of trait shame by communities that have some of that ideological persuasion that you're talking about, and what that then does to people and makes them vulnerable to diseases and deaths of despair. I think that's very real, what you're describing. And I think the implications are significant. Thank you for that question, Aaron.
Harvey Cohen has a question.
Hey,
Oh,
Keith.
no. No.
Yeah, nice to see you.
Harvey, I can't do this. Yes, sir. Yes, sir.
I want to pose to you, could we not, apropos of the last comment, could we not still collect information of the sort that was described, but use it humanely and have, in a sense, the best of both worlds?
You know, if people of the stature of, if healthcare leaders of the stature of Harvey Cohen will commit to that, I think we could in some way, Harvey. I worry that that we just don't have the ethical infrastructure to keep us all in line. But Harvey, I think there's potential. That's a conversation I'd love to have more with you. But yeah, I think we can work toward that. I mean, but my fear, what I have not seen is a lot of evidence of that commitment, Harvey. But I think there's potential there. Yeah, absolutely. So good to see you.
Great to see you. Love you talk. Nice hearing your voice again.
It's great to see you, and thank you for coming today. Thank you.
Brian has a question. He's raised his hand. Brian, go ahead and unmute yourself. Or
yes, I was curious if you've seen the documentary The Social Dilemma, and how we may take some concrete steps in, like the ideas of the friendship benches, that we can move towards cutting against the grain of these automated relationships and the idea of happiness, and move more towards in real life relationship.
Well, I hope we can, Brian. That's a great point. I've seen part of that. I haven't seen the whole thing. I think you're right on target to be asking about that. And remember that sort of the susceptibility to this is always there, I think, within the cultural milieu we live in. But if we can start to raise those questions and that you're pointing out, and start to interject the possibilities of, wait a minute, we've got to ask the questions first. We've got to be willing to say, wait a minute, is this right, what we're doing? Is this the right direction to be going? And then offer some of these possibilities. I've just given you two kind of different lenses you can think about today. I think there are a variety of ways, but with the notion of fundamentally, how are we taking care of humans? And what does it mean to take care of humans that are suffering as humans, but have all the possibilities of humans, and the sort of the fullness of that picture, and that what an opportunity for those of us who care for folks in one context or another to really digest that and think about the fullness of what that might look like. But thank you for that. I think that's right on target, Brian.
Thank you. Really enjoyed the presentation.
Thank you.
Christina has her hand raised. Christina, go ahead and unmute yourself and ask your question.
So much, Keith. I teach bioethics and healthcare policy at Azusa Pacific University. And we're now all on Zoom. And some of the courses I also teach are asynchronous. So in some ways, we have removed ourselves from the direct interaction with our students. And I'm concerned because there's some other levels of being with that Zoom can't capture. And as our students return to campus, we're going to be confronted with more needs that we have because of the how we've kept people out in the desert of